All right. So the organs of the nervous system as a whole will include the brain and spinal cord, the numerous nerves of the body, the special sense organs such as the eyes and the ears, and the microscopic sense organs that are found in the skin. So the system as a whole will consist of two principal divisions called the central nervous system and then the peripheral nervous system. Because the brain and the spinal cord will occupy a midline or central location in the body, together they are called the central nervous system or the CNS. Similarly, the nerves of the body are going to be called the peripheral nervous system or the PNS. A subdivision of the PNS, the autonomic nervous system, which is also known as the ANS, then that um, the autonomic nervous system consists of structures that regulate the body's automatic or involuntary functions such as the heart rate, contractions of the stomach and intestines, and then secretions of chemical compounds by. So, as we've talked about previously, neurons, those will conduct our impulses. Each neuron consists of three different parts. A main part of the neuron is called the cell body, and then one or more branching projections that are called dendrites, and then one elongated projection known as the axon. Dendrites are going to be the processes or the projections that carry impulses to the neuron cell bodies, and axons are going to be the processes that carry away from the neuron cell bodies. So these three main types of neurons classified according to the direction in which they carry impulses. Our sensory neurons are going to carry impulses to the spinal cord and brain from all parts of the body, and they're also going to be called afferent neurons. The motor neurons are going to carry impulses in the opposite direction away from the spinal cord and the brain. Conduct impulses to all parts of the body, only to two kinds of tissue, muscle and glandular tissue. And then these are also going to be called efferent neurons. Interneurons are going to conduct impulses from sensory neurons to motor neurons. They will often connect each other with each other to form complex central networks of nerve fibers. These are also called central or connecting neurons. Glia, these are going to be support cells that do not specialize in transmitting impulses. One function of glial cells is to hold the functioning neurons together and protect them. The reason that we want to discuss glia is that this is one of the most common types of brain tumors, also known as glioma, that develop from them. Astrocytes have thread-like branches that attach to neurons and to small blood vessels, holding these structures together. These branches will form a two-layered structure called the blood-brain barrier, which separates the blood tissue and the nervous tissue to protect vital brain tissue from harmful chemicals that may be found in the blood. Microglia, which are going to be smaller cells that usually remain stationary. However, when brain tissue is inflamed and degenerates, they enlarge and move around, acting like microbe-eating scavengers. Oligodendrocyte. These are going to help nerve fibers hold, it's going to help hold those nerve fibers together while producing a fatty myelin sheath that envelops a nerve fibers that are located in the brain and the spinal cord. The myelin sheath will affect our nerve conduction speeds. And then our Schwann cells, those are going to be glial cells that also form myelin sheath, but only within the PNS. Nerves are going to be groups of peripheral nerve fibers that are bundled together like the strands of a cable. Peripheral nerve fibers usually have myelin sheaths, which cause them to appear white. Each axon in a nerve is surrounded by a thin wrapping of tissue called the endoneurium, and then groups of these wrapped axons are called fascicles. Each fascicle is going to be surrounded by a thin fibrous perineum, and the epineurium, that is going to be a tough fibrous sheath that covers the entire nerve. Bundles of axons found within the central nervous system called tracts are also myelinated, and therefore they're going to form the white matter of the brain and the spinal cord. This tissue is composed of cell bodies and unmyelinated axons. And then dendrites is going to be called the gray matter because of its characteristic gray appearance. The brain, which is one of the four largest organs, is going to contain of the following major divisions. The lowest part of the brain stem is the medulla oblongata. Immediately above the medulla will lie the pons, and above that, the mid. Together, these three structures are called the brain stem. This medulla oblongata is an enlarged upward extension of the spinal cord. It lies just inside the cranial cavity above the large hole of the occipital bone called the foramen magnum. The pons will bulge out a little bit more than the medulla, forming a bridge to the narrower midbrain. All three parts of the brainstem function as two-way conduction paths. Sensory fibers conduct impulses from the spinal cord to other parts of the brain, and then motor fibers conduct impulses down from the brain to the spinal cord. The cerebellum, that's going to be the second largest part of the brain. It lies under the occipital lobe of the underneath the occipital lobe of the cerebrum. In the cerebellum, folded gray matter composes the thin outer layer and forms a large surface area of nervous connection that will allow for a huge amount of information processing. Most of our previous knowledge about cerebellar functions has come from observing patients who have some sort of disease of the cerebellum, as well as from some animals who have had the cerebellum removed. From such observations, we know that the cerebellum plays an essential part in the production of normal movements, and the most obvious functions of the cerebellum are to produce smooth, coordinated movement, maintain equilibrium, and sustain normal postures. The diencephalon is a small but important part of the brain that's located between the midbrain and the cerebrum above. It consists of three major structures. You have the hypothalamus, the thalamus, and the pineal gland. The hypothalamus is located just below the thalamus, just as the name suggests. The posterior pituitary gland and the areas of gray matter that are located within the side walls of the fluid-filled space called the third ventricle, those are going to be extensions of the hypothalamus. Measured by size, it is one of the least significant parts of the brain, but measured by its contribution to healthy survival, it is one of the most important brain structures. Some neurons within the hypothalamus function by making the hormone that the posterior pituitary gland secretes into the blood. Because one of these hormones, which is ADH, affects the volume of urine excreted, the hypothalamus will play an essential role in maintaining the body's water weight. The hypothalamus is going to be a crucial part of the mechanism for maintaining our body temperature. In addition, the hypothalamus is involved in the regulation of water balance, sleep cycles, and then the control of appetite and many emotions involved in pleasing, anger, fear, sexual arousal, and pain. Just above the hypothalamus is a dumbbell-shaped secretion of gray matter called the thalamus. It is composed chiefly of dendrites and cell bodies of neurons that have axons extending up towards the sensory areas of the cerebellum. The thalamus relays sensory information, associates the sensations with emotions, regulates level of consciousness, and participates in motor reflexes. Posterior to the thalamus, that's going to be a tiny protrusion from the back of the diencephalon called the pineal gland. It resembles the small pine nut or a kernel of corn. The pineal gland will receive sensory information about the strength of light that is seen by the eyes and adjust its output of the hormone melatonin. The cerebrum, that's going to be the largest and uppermost part of the brain. So if you were to look at the outer surface of the cerebrum, the first features that you might notice are going to be its many ridges and grooves. The ridges are going to be called convolutions or gyri, and the grooves are called sulci. The deepest sulci are also known as fissures. The longitudinal fissure that divides the cerebrum into the right and the left halves are hemispheres. And these halves are going to be almost separate structures except for an inferior central band called the corpus callosum, which is made up of white matter tracts. Two deep sulci will divide each cerebral hemisphere into four major lobes. and then each lobe into numerous convolutions. The lobes are going to be named for the bones that lie over them. So the frontal, parietal, temporal, and occipital. Specific areas of the cortex are going to have specific functions. And then this localization of function explains the specific symptoms associated with an injury to localized areas of the cerebral cortex after a stroke or traumatic injury to the head. On page 189 of your textbook, table 9-2, then that will summarize the major components of the brain as well as its major functions. So your spinal cord itself is going to be about 18 inches long, given that one is of average height. It lies within the spinal column in the spinal cavity, and it extends from the occipital bone down to the bottom of the first lumbar vertebrae. It consists of gray matter, and it's mainly composed of dendrites and cell bodies of neurons. Columns of white matter form the outer portion of the spinal cord, and then bundles of myelinated nerve fibers, which are the spinal tracts, will make up the white columns. Tracts are functional organizations in that all axons composing one tract will serve one general function. So these spinal cord tracts provide two-way conduction paths to and from the brain. The ascending tracts conduct impulses up the spinal cord to the brain, while descending tracts conduct impulses down the spinal cord from the brain. They carry impulses that produce our sensations of crude touch, pain, and temperature. In order to understand the spinal cord functions, let's think about a hotel telephone switching system. Suppose a guest in room 108 calls the switching system and keys in the extension number for room 520. Then within a brief second, someone answers within that room. So you have some different events that took place. The first event is a message traveled to the switching system from room 108. The system then routed the message along the proper path. So that was step number 2. And then thirdly, the message traveled out from the switching system into room 520. So the switching system provided the network of connections that made it possible to complete the call. So your spinal cord is going to function very similarly. It contains the centers for thousands and thousands of reflex arcs, and reflexes that result from conduction over arcs whose centers will lie in the spinal cord. Those are called spinal cord reflexes. Two common kinds of spinal cord reflexes are withdrawal and jerk reflexes. An example of a withdrawal reflex is putting your hand or pulling your hand away from a hot surface. And then a knee jerk is going to be an example of a jerk reflex. If an injury to a spinal cord cuts all the way across, then impulses can no longer travel to the brain from any part of the body located below that injury, nor can they travel from the brain down to those areas. So this kind of spinal cord injury produces a loss of sensation and a loss of the ability to make our voluntary movement. Nervous tissue is not steady tissue, therefore even moderate pressure can kill those nerve cells. Nature is going to safeguard the spinal cord and brain with a tough, fluid, cushioned set of membranes called the meninges. They will form a tube-like covering around the spinal cord, and then it'll line the bony vertebral foramen and the vertebrae that surround that spinal cord. So there's going to be 3 different layers. First, you'll have the dura mater, which is the tough outer layer that lines the vertebral column. Second, you have the pia mater, which is the innermost membrane covering the spinal cord itself. And then third, you have the arachnoid mater, which is in between the dura and the pia mater. The meninges that form the protective covering around the spinal cord also extend up and around the brain to enclose it completely. The fluid that fills the subarachnoid spaces between the pia mater and the arachnoid and the brain and the spinal cord, that is called cerebrospinal fluid, or CSF. It also fills the spaces in the brain called the cerebral ventricles. That CFS will form continuously from fluid that's filtered out of the blood in a network of brain capillaries known as the choroid plexus, and then into those ventricles. Most of our cerebral spinal fluid will make it through, or will move through tiny openings from the fourth ventricle into the subarachnoid space near the cerebrum. It then moves leisurely down around the spinal cord and then up and around the brain and returns to the blood. It's important to remember that this fluid will form our blood, um, or that this fluid will forms from the blood, circulates, and then is reabsorbed back into the blood. And so that will help you understand any abnormalities. If a person has a brain tumor that presses on the cerebral aqueduct, then it will block the way for the return of the CSF to the blood. Because the fluid continues to produce but cannot drain away, it then accumulates in the ventricles, creating enough pressure to damage or deform those nearby soft nervous tissues. The nerves connecting the brain and the spinal cord to the other parts of the body will constitute the peripheral nervous system, or the PNS. This includes the cranial nerves and spinal nerves that connect the brain and the spinal cord to the peripheral structure, such as the skin surface and skeletal muscles. These connect the brain and spinal cord to various glands in the body, and then to the cardiac and smooth muscles within the thorax and the abdomen. You have 12 pairs of cranial nerves. Those are going to be attached to the undersurface of the brain. The fibers will conduct impulses between the brain and structures in the head and neck and in the thoracic and abdominal cavities. So some of the examples are the second cranial nerve that conducts impulses from the eye to the brain, whereas the impulses produced are vision. And then the 10th cranial nerve conducts impulses between the medulla oblongata and structures in the neck and the thoracic and abdominal cavities. Now, if you want to know all 12 of those functions of those nerves, you can see on page 194, table 9-3 of your textbook, your anatomy textbook. Then it will give the names and describe each one of those nerves and their function. So you have 31 pairs of spinal nerves, and those are going to be attached to the spinal cord in the following descending order. So you have 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. Unlike your cranial nerves, your spinal nerves have no special names. Instead, they have a letter and a number to identify, so such as C1, P8, S5. After spinal nerves exit from the spinal cord, they branch to form many peripheral nerves out of the trunk and limbs. Sometimes your nerve fibers from several spinal nerves are reorganized to form a single peripheral nerve. So this reorganization can also be seen as a network of intersecting or braided branches of nerves called a plexus. Our spinal nerves will conduct impulses between the spinal cord and the parts of the body that are not supported by cranial nerves. And the spinal nerves will contain sensory and motor fibers. Spinal nerves, therefore, will function to make possible sensations and movement. The autonomic nervous system will consist of certain motor neurons that conduct impulses from the spinal cord or brainstem to cardiac smooth muscle, and glandular epithelial tissue. The autonomic nervous system will include the parts of the nervous system that regulate involuntary functions, such as your heartbeat, contractions of the stomach and intestines, and secretions of glands. On the other hand, motor nerves that control the voluntary actions of skeletal muscles are sometimes called the somatic nervous system. And the preganglionic neurons are autonomic neurons that conduct impulses between the spinal cord and a ganglion. Postganglionic neurons conduct impulses from a ganglionic cardiac, smooth muscle, or a glandular epithelial tissue. The autonomic or visceral effectors are the tissues to which autonomic neurons conduct impulses. So specifically, these visceral effectors are cardiac muscles that make up the wall of the heart, smooth muscles that make up the walls of blood vessels or our hollow organs, and then glandular epithelial tissue that makes up the secreting portion of a gland. Conduction paths to visceral and somatic effectors from the CNS somewhat differ. Our autonomic paths to visceral effectors consist of two neuron relays. Impulses travel over preganglionic neurons from the spinal cord or brainstem to autonomic ganglia. They are then going to be relayed across synapses to preganglionic neurons, which will then conduct the impulses from the ganglia to the visceral effectors. The ANS consists of two divisions called the sympathetic division and the parasympathetic division. So the sympathetic division and the sympathetic preganglionic neurons, these have dendrites and cell bodies in the gray matter of the thoracic and upper lumbar segments of the spinal cord. So because of this, the sympathetic systems also have been referred to as the thoracolumbar system. And that sympathetic preganglionic neurons, those have dendrites and cell bodies within sympathetic ganglia. These sympathetic ganglia are going to be located in front of and at each side of the spinal column. Because short fibers extend between the sympathetic ganglia, they look like two chains or beads and are often referred to as the sympathetic chain ganglia. The sympathetic division functions as an emergency system. Impulses over the sympathetic fibers take control of many internal organs when we exercise strenuously and when strong emotions such as anger, fear, and anxiety are elicited. Long story short, when we cope with stress of any kind, our sympathetic impulses increase to many visceral effectors and rapidly produce widespread changes within the body. The heart beats faster, our blood vessels constrict, which cause an increase in blood pressure. Skeletal blood vessels will dilate, which supply the muscles with more blood. Our sweat glands and adrenal glands will secrete more abundantly. The digestive contractions tend to become sluggish, and then therefore it will hamper digestion. Together, all of these responses will make us ready for that strenuous muscular work. We need such physiological preparation when facing a threat. Therefore, this group of changes induced by sympathetic control is known as our fight or flight response. The dendrites and cell bodies of parasympathetic preganglionic neurons are located in the gray matter of the brainstem and in the sacral segments of the spinal cord, causing it to also be called the craniosacral system. The parasympathetic preganglionic axons will extend some distance before terminating in the parasympathetic ganglia that are located in the head and the thoracic and abdominal cavities close to the visceral effectors that they control. The dendrites and cell bodies of the parasympathetic postganglionic neurons will lie in these outlying parasympathetic ganglia, and then their short axons extend into the nearby structures. Therefore, each parasympathetic preganglionic neuron synapses only with a postganglionic neurons to a single effector. This stimulation frequently involves the response by only one single organ. The parasympathetic system will dominate control of many visceral effectors under our normal everyday conditions. Impulses carried by parasympathetic fibers will tend to show a slow heartbeat, increased peristalsis, and increased secretion of digestive juices and insulin. Therefore, we can think of the parasympathetic function as counterbalancing that sympathetic function. Now, the sympathetic preganglionic axon, then and the parasympathetic postganglionic axon, those will release ACH or acetylcholine. These axons are going to be classified as cholinergic fibers. However, only one type of autonomic axon releases that neurotransmitter, noradrenaline. So this is the axon of a sympathetic postganglionic neuron, which is then classified as adrenergic fibers. And then the function of the autonomic nervous system, that is going to be to regulate the body's autonomic and voluntary functions in ways that maintain or quickly restore homeostasis. Many internal organs are dually innervated by the autonomic nervous system. So in other words, they receive fibers from parasympathetic and sympathetic divisions. Impulses from both sympathetic and parasympathetic nature will bombard them and then influence their function in opposite or antagonistic ways. All right, now that all the boring stuff is out of the way for the nervous system, let's actually talk about some of the pathologies or conditions that we might see. So, for conditions of the head and the meninges, cephalgia is just basically a fancy word for a headache. Migraines, these are ones that tend to throb on one side of the head, and sometimes they're accompanied by our nausea, vomiting, sensitivity to light or sound. Cluster headaches are going to be intensely painful. They will typically be a little bit less than migraine headaches, but they will repeat in clusters. Hydrocephalus is just an excess of that CSF that accumulates. And then meningitis, that's going to be an inflammation of the meninges of the brain and the spinal cord, and it can be caused by either bacterial or viral infection. Disorders of the brain, Chiari malformation, basically where the cerebellum extends into the spinal canal, so it does cause some issues there. Ray's syndrome is going to be a disorder in children. Sometimes it follows that viral illnesses when the child was treated with aspirin. Tourette syndrome is a neurological disorder, so you have involuntary tics, grunts, and utterances. And then dementia is a slowly progressive decline in mental ability. Some of our neurodegenerative diseases, these are probably pretty familiar to you. Your Alzheimer's disease, but it's just basically a group of disorders. It's not just one, but it does lead to a form of dementia. Huntington's disease, which is a genetic disorder, Parkinson's disease, chronic degenerative central nervous system disorder. Lewy body dementia is where the abnormal proteins interfere with brain cell function. And then amyotrophic lateral sclerosis, which is also ALS, also known as Lou Gehrig's disease. It's a rapidly progressive neurological disease, and it controls voluntary muscles. Brain injuries that we can see a lot are going to be amnesia, concussions, cerebral contusions, which is just bruising of the brain from bouncing against the skull. TBIs or traumatic brain injury, so blow to the head or penetrating head injuries. You have coup and counter coup, so basically a blow or a counter blow. And then lastly, that shaken baby syndrome that just results from a child being shaken violently. Loss of consciousness, you'll see that there is a measurement of response to arousal and to those stimulants. There's going to be different altered levels of consciousness or ALOC. So lethargy is just going to be that lowered slowness, drowsiness. Stupor is going to be an unresponsive state. Syncope is just going to be brief loss of consciousness. Coma is going to be that deep state of unconsciousness. And then that persistent vegetative state. Coma with alternating sleep and wake cycles. Brain tumors, so they can be anywhere within the brain, but your glioblastoma is just going to be a fast-growing malignant tumor within that glia. Malignant tumors, just tumors anywhere within the brain that will destroy that brain tissue. You've got your benign brain tumors, so they aren't going to spread or invade that brain tissue, but they can cause damage by increasing that intracranial pressure. So that's why it's important to have those diagnosed and removed. And then that intracranial pressure is just going to be that amount of pressure that's found within the skull. You've got strokes, also known as CVAs or TIAs. You'll use that FAST test to determine to see if a stroke is occurring. So if they have facial droop, they will tell you to lift both arms straight in front of you. One of them will typically drift off. there's going to be some type of speech abnormality, and then how long have the symptoms been occurring. Sleep disorders, unfortunately, insomnia is, I think, probably most common to all of us. Just prolonged and abnormal inability to sleep. Narcolepsy, where you just have uncontrollable episodes of falling asleep during the day. I know I suffer from sleep deprivation almost on like a daily, weekly basis, but it is like a lack of that restorative sleep. Parasomnia is going to be, it's going to occur while they're falling asleep, or even while waking from sleep. And then some of the spinal cord pathologies, you've got poliomyelitis or polio, which is that viral infection of the brainstem and the spinal cord. MS or multiple sclerosis, another autoimmune disorder, and it causes demyelinization from that inflammation. Nervous or like pathologies of the nerves themselves, Guillain-Barré syndrome or GBS, that's going to be an inflammation of the myelin sheath of the peripheral nerves. Sciatica is inflammation of that sciatic nerve. Trigeminal neuralgia is going to be chronic pain condition of that fifth cranial nerve. Cerebral palsy is going to be disorders that are caused by damage of the cerebrum, so poor muscle control, spasticity, speech defects, and then there's other neurological deficiencies. They can be caused by a brain injury that occurs during pregnancy, during birth, or soon after. Sometimes they are caused by that Chiari malformation that's up here on the disorders of the brain. I actually have a friend that her son has cerebral palsy because of a Chiari malformation. So they do tend to mimic each other. You don't always have cerebral palsy when you have a Chiari's malformation, but they can mimic each other. Epilepsies and seizures. So you have recurrent episodes within your epilepsy or your seizure. You can have single, multiple, or clusters. Your abnormal sensations, you've got some causalgia, which is burning pain that follows an injury to a sensory nerve. Hyperesthesia, which is excessive sensitivity to touch, pain, or other sensory stimuli. Restless leg syndrome, so an uncomfortable leg feeling in your leg. Typically it will happen at night when you lay down, but some people do experience that RLS during the day. So some diagnostic procedures that we might see, you've got some neuroimaging tools, so your MRIs, CTs, and your MRAs. Diagnostic techniques are going to be your functional MRIs, which will help detect the changes of blood flow within the brain. Your EMG, which is going to use an electrode that's taped to the skin, or it can even be inserted, kind of like a needling into the skin so that it actually goes down into those nerves and muscles. Your sedative and hypnotic medication. So these can just help, treat multiple different conditions. Anesthesia. So this is essentially going to be when we are trying to get to completely eliminate the pain. So your local anesthesia is going to be, obviously temporary. It's just going to be an injection. Topical anesthesia is only going to numb the skin or that soft or that top layer of the soft tissue. Epidural injections are going to be injected into the epidural space of the lumbar or the sacral region of the spine. And then your general anesthesia is what we know as anesthesia. Treatment procedures for the brain, you've got deep brain stimulation or DBS. Lobectomies are just going to be removals of a portion of the brain. Transcranial magnetic stimulation or TMS is where they send those electromagnetic magnetic pulses that will alter those electrical pathways. And then med term wise, for the nervous system and spinal cord, we've got these here. So your neuro for neurotropins, glial, ganglio, meningo, myelin, and reticulum. So all of those are just, again, those corresponding word roots with those nervous. And then word roots that are specific for the brain. So some of them are, for specific portions of the brain. Some of them are different states or minds of the brain. You've got your psycho, which is just of the mind in general. Somno is for sleep. Cortico is for that cerebral cortex. And then you've got your cerebrum, cerebellum, thalamus, all of those. And then here's some new suffixes that we didn't see in the beginning. So you've got your phasia for speech. Lalia is going to be for speech or babble. Plegia is going to be for that paralysis. Paresis is that partial paralysis. Phobia is just going to be a persistent or irrational fear. And then your mania is that excited state.